Hello everyone, my name is Chris Rude and my guest is Dr. Bruce Ferrin. Welcome, thanks for being here with me.
Glad to be here.
So Dr. Ferrin is a board certified adult gerontological acute care nurse practitioner. He earned his doctorate of nursing practice at the University of Utah. Dr. Ferrin works in the critical care medicine in the ICU at LDS Hospital here in Salt Lake City. His team consists of roughly 9 physicians and 6 nurse practitioners, and they all work for the larger entity of Intermountain Healthcare. Dr. Ferrin has been a nurse practitioner now for over a year, roughly 14 months, correct?
Right.
Great. So, Dr. Ferrin, think back when you first became a nurse practitioner and maybe explain some of the 1 or 2 of the struggles that you faced transitioning from the nursing role to the nurse practitioner role.
Okay. I think one of the biggest changes was a duration in perspective, meaning as a nurse I would come and I would work for 12 hours and say, how can I make this patient better in the 12 hours that I'm working with them? Whereas now coming on, you're looking at a continuum of health from illness to recovery, and focusing on what you can do in the long term to help patients get better, like preventing iatrogenic complications, looking at appropriate disposition and things like that.
Yeah. Okay. So consider your scope of practice and the regulatory bodies within our state. Do you agree with the regulations of your licensure designed by the state?
I think that working for this larger facility, I'm relatively satisfied. I don't deal with a lot of the oversight issues that I think nurse practitioners in clinics deal with. Here in the hospital, our licensure and privileges and things like that are all quite good, and we don't have so much oversight. We work as a collaborative team. Mm-hmm. So that's one of the bigger differences. But I do think that in the outpatient setting, there really shouldn't be the kind of oversight that's required in a lot of cases, especially along the lines of a narcotic prescriptions and opioid prescriptions. We've done schooling and training, and it's kind of impairing our ability to practice to the top of our licenses, I think.
Okay. So are there any changes maybe that you can think of that you would make to the credentialing or the clinical privileges here at your place of work within Intermountain?
In Intermountain, not especially in my clinical setting. Having been a recent graduate, I was frustrated by how long it took to go through the credentialing and privileging process, and I'm not sure what that looks like for other healthcare professionals, but for me it took a long time to get through, and it was frustrating being board certified, but then having to wait again another month and a half to get all of that sorted out. But
sure,
it may just be administrative paperwork type stuff. And again, I'm not sure how that would change, other than maybe to make it a little bit more quickly done.
And more streamlined.
Yeah. Ideally.
Great. So do you consider yourself in your field of medicine and where you work in the ICU, do you consider that a collaborative practice? And how often would you say you collaborate with other professionals?
Usually in the ICU, we collaborate almost hourly with different healthcare professionals. We have physicians that we work with. We have our nursing staff that do an incredible job there. We have a critical care pharmacist, all of the therapies, physical, speech, and occupational therapy, and other sort of consulting services that come through. So all day long, I feel like we're kind of bouncing ideas off of each other and looking at patients. And we have a formal rounds meeting where everybody who I think probably ought to be is sitting down in a room together with a large monitor, reviewing patient information and imaging and things, and coming up with a plan together. So we create kind of a shared vision and shared care model for each patient.
Okay, can you maybe share with us a scenario or an experience that you've had where you've consulted with other healthcare professionals and how that has in turn improved the outcome of one of your patients.
Sure. We had a patient just this last week who had a massive GI bleed. It was an arterial bleed in the duodenal bulb, and the patient happened to be about 80 years old and had an advanced directive that addressed some of the issues that we were coming up against in terms of, did they want to be intubated, did they want to be resuscitated? And we were trying our best to respect the patient's wishes and family's wishes at the same time we were trying to preserve this person's life. And what ended up happening is we consulted a social worker who was able to come down and work through advanced directives and the patient's wishes with the family, as the patient was unresponsive at that time. And then we consulted with some other specialists in the hospital, like interventional radiologists and surgeons as well, to get a plan together for this patient. And we actually were able to save this person's life, and I think we did a pretty good job respecting their wishes overall. They did end up intubated for, maybe 10 to 12 hours. Really just for procedures, but extubated shortly after, and is doing well to my knowledge now. But that was a scenario I think our social worker was invaluable, and these consulting services were great as we looked for different options that would work well for this patient.
That's fantastic. So in your professional opinion, Dr. Ferrin, what do you think makes a nurse practitioner distinct from a physician and even physician assistants?
Yeah, I think in Intermountain they actually lump nurse practitioners and physician assistants into the same category of advanced practice providers now, which is actually a step better than it was where we all used to be mid-level providers, which has some implications I don't think anyone appreciates. But what makes us different from physicians and physician assistants, I think, most importantly, is that we were nurses first, and still are. The perspective of care comes from care delivery at the bedside, and that's where my expertise, and I think our expertise are. There's a lot of that that's missing from, I think, the physician and physician assistant care models.
Sure.
Well, I'm trying to think. We have extra training in terms of, and education in terms of prescriptions and physical assessment and diagnoses and research and things, but that focus on care delivery at the bedside and making things happen to really, in a meaningful way, improve patient outcomes, I think is what makes us different.
Sure. And what qualities and characteristics would you say best define a nurse practitioner, or how they can be successful in your field of medicine?
I think that it depends on why you got into this field. I have some colleagues that were interested in measuring success by revenue, which is fine. I think probably a lot of people do. And they're working in cosmetic and Botox type clinics and make a good living for themselves, and that's good. I think in critical care medicine, where we work, I think success is largely measured by patient outcomes, and the qualities that make a nurse practitioner successful in that setting is I think, one, creating, and two, owning care processes that do improve patient outcomes. In our ICU, we try and focus on create a safety program, or have created a safety program there, where we round with nurses twice a day to help prevent complications of being hospitalized, for complications of hospitalization for patients, or complications of an ICU stay, like delirium and post-ICU syndrome, things like that. By keeping our patients awake and participating, writing longhand notes while they're intubated even, to keep them active and strong, and ideally discharge home. I think There has been some research that demonstrates the use of advanced practice providers, nurse practitioners in the ICU setting helps reduce, intubated days and reduce discharges to skilled nursing facilities rather than home and things like that. So that's how I like to measure my success in our setting, is if we're making meaningful change in patient outcomes that way.
Sure.
Yeah.
Okay, well, thank you for your time.
Sure.
I really do appreciate you taking time out of your busy schedule to fit me in and do this with me and doing this interview with me. So thank you very much.
Glad I could. Hope that was helpful. Thanks,
Yep.
Chris.